We'll begin with the Pledge of Allegiance.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Good morning. Welcome to the October 28, 2024 work session for the Shawnee County Board of County Commissioners. My name is Kevin Cook, serve as the chair this year. Joining me today is Commissioner Aaron Mays. Good morning. Good morning. Commissioner Bill Rippon. Good morning.
Morning.
Ms. Beegers filling in for Mr. Eckert. Good morning.
Good morning.
And our presentation this morning is on Nurse Navigator. So Nelson, I'm going to turn it over to you to talk to us and give us an update.
Morning, Commissioners. Nelson Castile, Ambulance Compliance Officer. Pleased to be here today to provide a report on two of the initiatives and innovations that were a part of Contract C71-2023. I'm going to grab the right mic here. Here we go. So in January 2022, the Commission directed county staff, myself, and others to implement the Nurse Navigation Program as an amendment to the current contract. We also put some other items in there that we're going to cover today and provide an update for. The pilot program for the first 2 years, and those first 2 years started on April of 2023, were provided by $60,000 each year from the ARPA funds that the county received as a part of the American Rescue Plan Act. Also a part of that was the third dispatcher, which that came out of the same ARPA funds, and then it was taken over by the general fund each year in the budget for the last 2 budget years. We worked together with a lot of folks here throughout Shawnee County. I have with me today John Antrim from AMR, one of their regional directors, his folks, the county 911 center, the sheriff's office, all of our stakeholders across all the first responder agencies worked for about 13 months to get to where we are now. In February, a contract was signed of that year, that'd be 2023, that implemented this, that implemented what we're going to, part of what we're going to discuss today. It had other changes, but these are the 2 major ones that we wanted to see. And so on April 25th, 2023, all of that pretty much kicked off, and we've seen some good results out of it. Like most of my reports, we kind of just deal with a question. I try to answer those questions as completely and as efficiently as we can. We're going to start with the first topic. It's not the least topic, of course, but it's one that we'll breeze right through, and then we'll get into the meat and potatoes of nurse navigation. And those questions are: is the third dispatch position at the AMR console's vital solution moving forward? And number 2, is the Shawnee County Nurse Navigation Program a viable solution moving forward? And we'll have some answers to both of those. And before we go on, this is kind of the checklist, I guess you could say, of the things that I undertook during the last, I believe it's probably about 16 to 19 months. We observed on site how some of these happen. We monitored the radio, did a lot of research via the recordings to match up a lot of the calls for Nurse Nav and the third dispatcher. We went from what I will call a cradle to grave philosophy. We went from where it started to where it terminated and looked at all aspects of that. We looked at the patient reports and the nurse reports. These were invaluable. AMR provided these upon request very quickly, allowed me to go in there and do research and look at anything I had questions about or needed clarifications on, or if it was one of the times that I just picked some random reports to look to see how we were doing there. And then we were in regular communication with AMR management. Mickey Huber handles most of the operations here with Nurse Nav, along with Melanie Burgers, who is the communications manager, and then with John that he's kind of overseeing it. They've met on a monthly basis. Some of those meetings I've been able to attend. In most cases, John has gone in and talked to the GMR and the AMR folks about concerns that we have brought up. So we'll just start with the third dispatcher. This started out as a pilot, but based upon my recommendation, the Board of County Commissioners saw fit to continue it. This put This put a third dispatcher in the center for no more than 12 hours a day. I will say that that has been a very good success, and I'll show you some figures here in just a second. It allowed 2 dispatchers to always be on the radio, always to be on the phones. That center has seen an exponential increase in the number of medical calls that are coming in to AMR, and that has really helped to fill those gaps during the busy periods. It's not hitting all the busy periods because this system is very unpredictable. There are some times when 2 a.m. is a busy period, and other times when 2 a.m. is a period where they don't get anything. So one of the biggest morale boosters, I think, is it allowed the AMR dispatchers to have some breaks away from the floor. When there was only 2 people in there and they took a break, that left 1 person in there. There were numerous times that they had to arrange to get the other person back in there. It was sporadic, but it happens. That's a long time to be on the phone. They have since implemented some policies that allow them. They're supposed to go through the full emergency medical dispatch and come up with a terminate code. On the minor calls, sometimes they have a very quick disconnect, and then I look at those calls, make sure there's no negative patient impact. But that got them in there. The interfacility and the card 33, those are the ones from specific facilities where they've been, the request was issued by a doctor or an RN, and they're already in a high level of medical capabilities there. So those are the ones that we exempted as a part of contract C71-2023, and that allowed them to be able to schedule some of those, or at least work with those folks to get them, and not have to go on and off a hold several times if other 911s come in. Served as a third set of eyes, and also helped on some of the wrong information and bad information that gets out there on addresses. It is shocking that, well, it shouldn't be shocking because it happens every day, but there are a large number of people in Shawnee County that do not know where they are, so they have to work with the 911 center, work with the AMR dispatchers and figure out just where it is that they are. The technology is there to do that, but it still takes some work to do. During 2023, this review is June 2023 through May 2024, as indicated in the report. We chose that because we started on April 25th. It didn't seem fair to do anything in May. Those were some growing pains. We had a lot of meetings. They worked out some issues that had been brought up. So we did June 2023 to May 2024. These are the number of calls. The big chart is the 911 calls, and apparently I broke it already. So the previous to February through May, we were always in that upper 90% on the 10 seconds. You're going to see in February, March, April, and May that those had dropped, and there's a reason for that. Those are the months that they were not able to provide more than 2 dispatchers in there for the longest time. They had some approved leave that went on. They had some turnover. They just were not able to get those folks in. To remedy that, I do know that Director Bergers brought in somebody from Sacramento, brought in somebody from Seattle that dispatched for 45 days or so, I think it was. Tremendous dispatchers. They augmented in very well, and they were actually the second body in there. They barely had enough to put 2 bodies. So having these out of the region dispatchers in provided them with some much needed rest, because they were working a lot of 12 on, 8 offs with no days off, and AMR worked with me on that. The reason I share that is, I'm going to go to the next slide. We're going to extend it out to September here. If you look, when AMR was able to get a third dispatcher back in there, that would have been June, those numbers went right back up. 1.5% to 2% may not seem like a lot, but when you put that over the 30,845 calls that they handled in that, 15-month period, that's a significant number that they did. This chart is available, both charts are available in the report. I would also put your attention over on the left-hand side, and we're going to go back one. During just the June to May, there were 16,729 calls admin-wise, which means when you add that up, that's it's just a little over 40,000 calls that they handled in a 12-month period when you look at those, and we're going to go the right direction here. When you look at the 3 additional months that we added in there, 21,891, and add that in, that's over 50 to 51,000 calls. So that we don't have the timers on the admin calls, but when you consider the number of calls that are coming in, you can see that that's a lot for just having 2 people at the consoles 12 hours a day. So in answer to the question, is the 3rd dispatch position viable moving forward? Yes, it is. I think it has helped tremendously get that call load down. It's transferred some of that call load. It is also a morale booster, and it's also a more secure feeling for our county dispatchers. When they transfer that medical call over and the phone continues to ring and ring and ring, and they're dealing with the emergency plus everything else going on in the room, we saw that less in those times where it was 95% and higher, where we had the 3rd dispatcher. It's a very good level of comfort in there when that happens. So I do recommend it as one of our multi-pronged, multi-tiered tools here. It's one of our truly good innovations that we put in place, and I think we need to continue it forward. And I'll be covering that at a later meeting here, probably in November, to let you know what we're thinking about doing with it. So I'll stop here for any questions.
Questions for Nelson? All right.
Okay. The nurse navigation, this was we started on January 13th, 2022. Took us about 13 months to get it lifted off. There were a lot of things that we had to change, a lot of things we had to refine and modify. We have seen some benefit from it, and you'll see it on one of the later charts here. So some of the things that we saw through this example, I explained to you, I went through each and every call, cradle to grave. That's why it took us a little bit to get to this point, just to find out what it is and what were some of the common denominators that came about. And it did remove a large number of calls from the 911 system, meaning they could use what was triaged by the nurse, and it did not require a response time. There were some calls that did, and we'll go through that in just a second. I mean, it definitely alleviated the stress. I believe there's in mine, we went from June to May. What John shows you is probably going to be the program as a whole. Again, we didn't want May to be, May was one of those that we thought, that's the growing time. Let's wait to June and start getting some full months in there. It helped with the triage and prioritization of calls that were being held, meaning that if it only required a BLS response, they could wait for that till a BLS unit cleared from a hospital or from their call. Same thing that they do when it's under compliance, except they had somebody that actually triaged it and said, hey, this meets this, let's do it this way. So it did help in that aspect. Surprisingly, we had a couple, I didn't think we'd have this problem, but I figured we'd have the opposite. We had 6 people that regularly would call during the first year and say, I don't want you, I want the nurse. So and those were calls that ended up not having to be in there, and John's going to go through what all the options were, but it was really encouraging to hear somebody that wanted to talk to the nurse and not just demanding an ambulance. Of all those calls that returned to dispatch, For the immediate emergency response, there were no negative patient impacts. I asked Dr. Thompson several times, we communicate on a regular basis, please provide me with any of those. We had some that were turned in that were really not a negative patient impact, and I'm glad to see that was one of the things that was brought up as an impediment to this program. I'll stop here to ask if there's any more questions.
Questions? All right.
In going through every call, this graph here, the blue line is the current on-time performance for those 12 months, June to May. That's what we reported as compliance. By going through there and looking at each call and then putting those calls in the system and following the calls to figure out where it helped or it did not help, if we had not had nurse navigation and that ability to triage and kick it out of the system, we would be I believe that's an orange line there. As you'll see, some of those dip down into the 70s, which means that would have put them out of compliance. So they depended on the nurse navigators to help them. That also helped them with units on the street, getting the right unit to the right place at the right time for the right reason, which is one of the things that we try to strive for here. This is what came out of my result, going over each of the calls. John is going to have a little bit different, but the calls that they ran, that's 1,191 calls. ALS coming back, that's 53. I will tell you, only 3 out of those 53 were really ALS, which when you consider the total that they are, it's 0.3% that came back from the nurse that required an ALS response. The rest of them, the 718 plus those 50, those were BLS responses. The nurse navigator sent them to the ER where they referred to an alternate destination. Self-care, we saw a lot of those for the self-care. I believe we even have that as a part of our program here, as you call the nurse or doctor or whatever it is. If you're a county employee, instead of having to go in, you can do some telehealth. There's some virtual care there. I'm very pleased to see these numbers. I think we've got a good thing here for the system. While we have some good things here for the system, here's what we found by going through all those. People don't like the warm handoff very much. Let's just say that they could be very colorful in their responses to that. John had to work with the nurses. There was an unfamiliarity with the nuances of our community. We have a community here that we're changing the EMS paradigm in this county, and it used to be that you called 911 and a fire truck and an ambulance showed up really quick, and we still do show up really quick, but it's done according to prioritization and triage. During specific hours, there was no alternate facility. So if you called at 4 a.m. and you were impatient and you couldn't wait till 8 a.m. to get to a doctor or get a ride or something in Lyft or anything like that, then they ended up coming back into needing a unit to transport them. They're working on that. There were, and this is the slide I was referring to, I guess I got a little bit ahead. When the nurses said it required an ALS response, those are those 53 in that column. We looked at them with the joint medical director, with operations manager Mickey Huber, Ann Antrim, who was at CES over there, and looked at them and saw that only 0.3% were actually ALS calls, which is pretty good. It also reinforces, and I did not put it on here, our BLS crews. They ran a lot of these calls for us, did an outstanding job. The BLS has really helped add to that and keep those ALS units available for the more serious calls. We did have, and we still do have, when the calls come back, there's a special coding, just like when you go to the doctor's office. They got all that list of codes that they got to put in, so the insurance people pay you or don't pay you, or they argue with you. Well, the nurse navigation side of things, some of them would get coded wrong, so first responders would end up going, and we continue to deal with that. The one that we have obviously a lot of work for is trusting. What does the EMD tell us? What does the CAD tell us? This is not unique to us. It happens. We run into the same thing in a lot of systems where they don't want to trust that computer to just make that decision. And that's something that AMR is working with. I understand it goes on in other systems. I will also say it goes on in part of the program that John Anterman introduced of the air assets. They'll see that pop up. It's just one of them things we'll continue to work on. So this is the question about the nurse nav. It was a force multiplier. It was one tool, and I think there are some things that we utilize out of nurse nav. I think that we can integrate that in to where we want to go in the future. You've seen from the stakeholder groups and the working groups, the committees, the task forces, some things that we'd like to see in the EMS system, and this is definitely one of them that is a winner on it. And so with that, that's the first part of my presentation. Before we turn it over to AMR, is there any questions, comments, concerns? Stand ready to answer them.
Questions for Nelson?
Oh, maybe it's a question for John, I don't know, but like, when we look at 911 ambulance calls prior to nurse navigation versus after, I would say after, because like, I know that first year was kind of a ramp up, that I kind of throw that out, but like where we're at now, like if you look at the month of September this year versus the month of September in 2021, I mean, is there a pretty stark difference between the two in terms of actual like vehicles being sent out?
There is, 2021 is not a good year for
Okay,
comparison.
2019, how about that?
Well, for 2019, before the pandemic, we're seeing right now in the full years of 22 and 23, we saw AMR basically handle 14 months of calls in a 12-month period. And even though we're kicking out probably about 1,000 a year, we are still seeing an exponential climb up of ambulance calls across the whole system. I don't know when it's going to stop, but this will be another record year for our first responders and the ambulance service. We are, post-COVID, we are seeing an increase in calls. It took 1,191 of them out of the system. To me, that's significant. That's about half a month's calls. They run into 2,000 to 2,300 months a call. So it is having a difference. The biggest thing is we're looking at the system as a whole, because we are seeing much longer wall times. If you've seen the articles in the newspaper and on television, we have longer wall times. Ours are not as bad as some of the other systems around us. And so this helps by being able to schedule those. And it also helps when they take them in there, because 9 times out of 10, if they're coming in, they can have a quick turnaround. The BLS units, those folks are just doing outstanding with their wall times of between 7 and 11 minutes, which is really quick to get in and out of the hospital triage areas. 20 and 21, we pretty much, those were just, there's nothing to really compare them to, because we had COVID going on every other call, if not every call in an hour, sometimes was COVID related. But to 19, we have seen an increase in calls over 19. That was our biggest year to date before COVID hit. And since then, 22, 23 are the biggest years, and 24, I can see another big year happening here. And I'll also let John, because he gets to see all the AMR stats, but as a system, looking at our system, Just this weekend, we had 6 out-of-county ambulances dropping patients off at Stormont Vale and St. Francis. And of those 6, 2 of them very seldom come here, and they came here twice. So they're staying busy. Everybody's staying busy. I hope that answers your question.
Yep. Thank you.
Thank you. Other questions? All right.
See if I remember how to do this. She taught me before you guys got in here.
There you go.
Well, good morning. John Antrim, Regional Director with AMR. First and foremost, I want to thank Nelson for all his hard work that he put into that report to really talk about some of the innovations and things we've been able to accomplish through our partnership. So this morning I'm going to talk a little bit about nurse navigation. I'm going to do a 12-month look back into the system, probably during the busier times. So we're going to talk through this. Like you mentioned, it was a new program, so there was some learning and some growing pains that we had to go through. Getting our communications center to trust the EMD process, to send them to a nurse and not immediately want to send an ambulance was a little bit of a struggle, but we've been able to work through and navigate some of those things, as well as the third dispatcher has been a tremendous asset, not only for our staff as a morale booster, but also for service to the community members when they call 911. So the national standard for 911 calls being answered within 20 seconds is 95%. As you can see by those reports that Nelson showed you, we have exceeded that and been able to provide quicker service to the community members, so that's very, very important. So with the nurse navigation process, I just want to do a real quick overview. I think you guys completely understand how this works, but in case there's anybody watching or anything, that's probably one of our biggest problems. And I'm going to show you at the end of this, there are still some people, while there are people calling asking to speak to the nurse, there are some people that are still refusing to utilize the nurse service, right? So I think community education is going to be a big piece for us moving forward. So in the nurse navigation model, when the caller calls 911, they immediately are transferred to one of our dispatchers within the comm center here at CECC. And that dispatcher runs through that emergency medical dispatching triage process. Once they've completed that process, there are a select group of EMD determinant codes, is what we call them, that have been flagged by the medical director, as well as working with stakeholders and with the ambulance compliance officer, that are approved to roll to the nurse. That nurse then takes that patient. Typically, they're answering the phone within 22 seconds. Once they're transferred, they're getting answered within about 22 seconds, and they're running them through another triage process. Now, based on the results of that triage process, if you look to the right, there's this fancy algorithm called MTARA, which is needs matched, time appropriate, resource allocated. So that's really the goal of this program, right? So we want to make sure that we're taking the patient in the community, and this is something that doesn't need to be rushed to the emergency room, so maybe it's more appropriate that we take them to the local urgent care center that's 2 blocks away. Or maybe it's something that can be handled via virtual care by a physician on their smartphone, or maybe it's something that could be handled by the nurse just giving self-advice. So, and we'll talk a little bit about that. So once that assessment is done, the nurse then kicks it back to us if it requires transport. And the beautiful part about it, like Nelson alluded to, was they now have been screened by a health professional, and they've ruled out that there is not an immediate life-threatening emergency. So the nurse will tell them, hey, we're going to go ahead and have you sent to the emergency room because that's maybe the only resource that's available to you. However, it may be up to an hour before we get you transported to that location. So, and we've really had some great success with that. So what that does is it, number one, keeps our resources that are available to run those high acuity emergency, those strokes, those heart attacks, those trauma calls. It keeps our resources available so that we can handle those lower acuity calls at a later date. It also has had some great benefits for our first responder partners in the number of calls that they've actually had to roll on where previously they would not have. So, but again, what's the appropriate time? Do they need to be seen right now? You know, even the ones that are coming back from the nurse, like Nelson showed you, that said they need to be seen right now, a very small portion of those, once we actually get on scene, are actually going to be a life-threatening emergency to the tune of about 0.3%. It's like like he pointed out, that are actually life-threatening emergency that needed an immediate response. So this kind of talks about the maturity of our program. As you can see from the first year, only about 3 to 7% of our calls actually enrolled to the nurse navigation program. And those were all just some pain points and growing things that we had to work through in getting, number one, our dispatchers comfortable in doing that, and then actually rolling them to where they need to go. Phase 2, we're about 7 to 13% of our call volume is actually rolling to the nurse nav. And the hope is by the end of phase 3 that we're going to be at that about 10 to 15% growth of our calls rolling to nurse navigation. We're going to talk about some of the things here in just a little bit and some of the initiatives that we're going to move forward with. So the medical director is looking at current EMD codes. Luckily, Shawnee County is not the first place that we've been able to do this in, so we have some great success stories across the United States. So we're learning about different codes that maybe we weren't using before that are appropriate for the nurse, so we're going to start reviewing those and moving those things forward. I think some of the big things we have to do is we have to look for expansion of alternative resources. Both hospitals and both hospital urgent care systems have been amazing, and they have adapted to this, and they have done a great job allowing us to use their urgent care centers. Probably the biggest challenge and probably the biggest piece of the puzzle that we're missing today, and I think I've mentioned this before, is our federally qualified health center. That we really need to be able to get those patients to that federally qualified, those underfunded or uninsured patients, to get them into their system so they can help navigate them to primary care, help navigate them to get Medicaid or Medicare for themselves, and then also get them into primary health care, because a lot of times EMS becomes and EDs become primary health care for people that don't have that ability. So hopefully we'll be able to continue to work and expand those. So this is a little bit of financial impact, and this is a 12-month look back from 8/1 of 23 to 7/31 of 2024. Again, only of 1,250 calls that went to the nurse, only 55 required an emergency response. 734 of those came back to us for BLS transport. 2/3 of those callers still, even though it wasn't a life-threatening emergency, it wasn't something appropriate to be seen in an emergent or in an urgent care type center. So still resulted, but the other third had mobility issues. So whether they were bedridden or you're not able to walk to get to the Lyft or Uber or rideshare that we've utilized. So a third of those still required some additional support because of mobility issues. And then 461 during that 12-month period did not require any response from a fire or EMS or from us. Quarter of those we utilize rideshare to get them to the emergency department. This is something new that actually started this year. So Lyft and our rideshare partners were not comfortable originally taking patients from their home to the emergency department, but we've been able to work with our rideshare partners now that they've been assessed by a healthcare professional or nurse, that they will now actually take that patient. So they're still going to the emergency department, but it's freeing up our resources on the EMS side, and it's also a financial benefit to the patient as well, because they're not receiving the ambulance bill, and the ride share is all funded through the program itself, so there's no cost for Lyft to get them there. They'll actually take them home at the end of the visit as well, and if they need, they can add a stop to a pharmacy or something like that if they need it as well. Half of those 37% receive self-care from the nurse. So the nurse, hey, sounds like you have flu, cold, take some ibuprofen, Tylenol, drink lots of water, and then they call back within 24 hours. So anybody that does not get transported, the nurse does attempt to call them back 24 hours later, and they'll do that for 3 days in a row. And I'm going to show you some interesting data and statistics from when they've called those patients back about patient satisfaction, and then some other interesting data that we're receiving from that. So
Before you go to the next slide, what would be an example of somebody that is taken by Lyft to the emergency room?
it may be, abdominal pain or, something like that, a spider bite or that's got some localized swelling but not involving respiratory or any type of priority symptom, chest pain, difficulty breathing, anything like that.
Okay. All right, thank you.
And really down here is just a little kind of a financial snippet of, financial benefits to the residents of Shawnee County. So avoided ED visits, there are approximately 88. Now that assumes that nurse navigation calls self-care would have been a refusal, or that the call was resulting in alternative care would have been an ED visit. But you know, that's approximately $198,000 in the last 12 months of savings to Shawnee County residents, avoided EMS transport fees, and using Lyft, again, another big bucket of about $96,000. So you can see that this program really also is aimed to helping serve those underserved and those that, this shows that it's been a great financial benefit for those patients that fit into that bucket. So this is kind of a, this shows the payer mix up in the right corner of the slide there. Shows the payer mix of the patients that have utilized the nurse navigation system. So you can see 7% are uninsured, 24% are on Medicaid, 35% Medicare, 15% commercial, and then you know the other bucket could be like VA or some of those other non-healthcare systems. So a large portion is that low care or low pay or no pay population that this is serving. This is the interesting part. So the bottom, reasons for calling 911, that's part of that callback survey. When they call and check on them to see how they're doing, they also ask them a question of why did you call 911? And you can see the largest proportion, the largest percentage, 34%, is when they call those patients back within our community, 34% of them said they didn't know how else to get care. They didn't know where else to go, they didn't know what else to do, so they called 911. 30% is number two, and they perceived that it was a life-threatening emergency. And then 11%, and I think this 11% here gets surprised very quickly, and Nelson can confirm this, but just because you take an ambulance to the emergency room doesn't mean you automatically get a room. So when we give a report to the hospital and you're one of these low acuity patients, a majority of the time you'll bypass right through the emergency room and go right to the triage, to the waiting room, and set up there in the front. So, and then 22% had no other means or transportation, and then 2% had problems getting appointments. So when I talked about the callbacks, this is the current score. So 4.8 out of a 5 scale is what the community members are saying in support of this program. So when the patients are getting to the program and they're getting the services and they're utilizing it, they are appreciative of it and they are giving great results. So, you know, one of the question categories was the time adequate? Did the care you receive? Was it communicated? Reception, technology? Did you have any issues with the visits if you had to do telehealth? Transportation, and then wait times, specifically for getting back home after your visit. So this is really great testament to how well the program's working and how the community members are receptive of it. So some of the things and the increased opportunities and some of the headwinds and tailwinds that Nelson talked about, you know, we've got to review and validate our protocols to ensure that first responders are not being sent. This was a problem definitely in the beginning. Everybody was getting sent, but there's been a lot of work done by Mel and Mickey at the local level. They receive a weekly report now, and that weekly report shows the number of calls that should have gone to Nurse Nav that maybe the dispatcher chose not to. One of the challenges that we had was the dispatchers would start to look into the call a little bit. And, oh, you've got mobility issues, so we're not going to send it, even though it still may have been completely appropriate for a virtual care visit. So we've been working with our staff, and they've done a tremendous job in righting the wrong in doing that, and the same with the first responders. You know, the call determinant codes, reviewing those to make sure that we're utilizing the appropriate codes. Can we add some more that are appropriate that we're currently not doing? All of these are things. The other big piece, and it's been a little bit of a struggle, but it's been a great success in other communities, is people will skirt the EMD process. There are people in our community that will use the appropriate buzzwords to get an immediate response, right? And then when we get on scene, it's something low acuity, didn't require an immediate response. So what we're trying to do is figure out a way. We did this during the Arden cyber attack. We were able to put a protocol together and throw it into the system relatively quickly to allow the first responders that maybe get there before us to realize that this is a low acuity call and allow them to activate from the field nurse navigation and send them to a nurse versus waiting on scene with this low acuity patient for us to respond. So these are all things that are, you know, future state that we want to continue to work for. There's obviously some communication issues, and you know, not everybody has cell phones on their apparatus and those kind of things. So things we need to work for. So again, Nelson kind of talked about this a little bit. One of the big problems that we have with referrals to alternative destinations, all of our alternative destinations today open at 8, close at 8.
Oop.
Emphasize it. Mic drop, I'm done. You guys are looking at me like I wish he was done, but hurry up. But so one of the things, like I said, all of them open at 8, close at 8. So based on that MTARA scale, like Nelson said, if at 4 o'clock in the morning they need to be seen within 3 hours, they don't meet the criteria, so they're going to end up getting transported to the emergency department. So we've had some meetings with our urgent care and hospital partners to, you know, hey, would somebody maybe be interested in doing 10 to 10? And I'm going to show you why that's important here in a little bit. But that definitely is one of the challenges. Here's probably the biggest one, and I've got it kind of circled in red. A large portion, 42 to 40% of our community, when they're offered this service, refuse it and say, no, I want to be transported by ambulance. So this is probably our biggest opportunity to start doing some public health education and some community education to look, you're still getting care, you're getting more cost effective, you're getting most appropriate care, plus you're keeping resources that are important free and available to respond to those true emergencies. But this is definitely one of the biggest areas that we have to continue to try and improve on, is when the nurse says, hey, I'm going to send Lyft to pick you up to take you to the St. Francis urgent care, that patient says, no, I want to be transported by ambulance, because that is a big chunk of where we can make an improvement. And again, I think it's all part of these growing and learning pains as we move through the system. So the blue scale there, that shows kind of the hours. If you look at the bottom, midnight to 4 o'clock in the morning, 4 to 8, 8 to 12, 12 to 4, 4 to 8, and 8 till midnight. So you can see a large portion of those calls happening after midnight and before 8 o'clock in the morning. So during those peak times, you can see our clinical referral rate's a lot higher, and then it drops off significantly on those overnight hours. We do keep a very detailed list, and Nelson has access to all this reporting as well of where these patients are being transported, what alternative destinations. The alternative destination partners have a portal that they can go into. They can also see and track that stuff as well. But a large chunk is occurring. Now, I will tell you, when we first started this in the first year, 70+% was coming back to us, you know, and that's immediately, Nelson talked about it when we went to the nursing navigation team and said, this is not working. We've got to figure out something different. What are we doing wrong? What can we do? What are best practices? So now we've definitely seen a steady decline in the number of calls that are coming back to us. I would like to see it decline even more. But until we work through some of these tailwinds here, or headwinds, then, you know, we're probably not going to see that. Any questions?
Questions for Mr. Andrew? No? All right, none at this time.
It's good information.
Thank you.
Thank you.
All right. Thank you, John, for providing that. As with all our presentations, we'll make those available so those that are online or anywhere out there can have it. So before I go into some recommendations here, we are in the last 2 full years of our contract with AMR. That contract was signed in July of 16, and it was 5 years. We extended it another full 5 years, and so we have 10 years of this contract. The nuances and the challenges and the complications in the post-COVID EMS operations every day we get a new surprise about how it works, some things that are thrown at us. I would like to say we do have, and some of you were able to attend in July, I believe it was, for 40 years, AMR or whatever they were called in the 80s, 90s, and the aught years, were the 40 years of contract with us, with the county. We've seen some really good, and like I said, I have to thank all my stakeholders that are out there in the community that have helped us with this. We've got some really good relationships going on. And then AMR and John, when we've been through some of these task forces, working groups and committees, John has said, you know, if you have something you want, we'll provide you with a price. And so I think that, because of those facts that I gave you, I think we look towards AMR. I've worked quite a little bit with the county councilor on this recently to provide some specifics to the Board of County Commissioners, and then provide those to AMR and see what their pricing may be. There's a lot of innovation and components out there I think that we can add. Nurse navigation is one of those invaluable tools. And then I think that with the contract ending in April of 2025 for Nurse Nav, I think that we encumber any funds that we have at the end of 24 and continue to pay for the Nurse Nav through January 1st of 2026. We'll know better probably by budget time next year just where it is we want to go and how much we'll have to spend going forward. So I stand ready for your questions.
Nelson, the nurse navigating system, that was a significant investment by the Shawnee County Commission into this, having this set up with the idea of relieving some of the strain and stress of the emergency rooms. I think we're starting to see some of that, but is it still too early to tell the full impact? Because, I mean, if I was looking, go back at the chart you had, I mean, it looked like we were only about halfway through moving from a 3% referral to a 7 to 10% to get up to that 10 to 15% referral.
The ER visits are not down for anywhere. As I showed in my monthly reports, we're seeing tremendously more calls every year. 22 we thought was a record. 23 became a record when we did Nurse Nav. So we are seeing less of them going to the ER. The biggest impact we're seeing is it's allowing AMR to get there to the other calls quicker when they don't have to commit to compliance on a low acuity call. So I think that we are seeing it. I think another year we will, with John working through some of the issues that he mentioned as well as some of mine mentioned, I think that we're probably going to see those percentages significantly different next year about this time.
I think that it's also just a little bit puzzling where even where it's identified that there's not an ambulance needed, you still have a high percentage of individuals that are requesting an ambulance even where it's not needed.
Yeah, so John Antrim, Regional Director for AMR, and that's one of the things that I think when we talk about innovation within the system, of how do we approach that as a system. Like, once you've now been evaluated, a doctor says or a nurse says, you don't need an ambulance. You know, today, under current regulations and current things that we have within the state of Kansas, we can't refuse it, right? And by our current contract, we can't refuse it either by saying we're not going to go. But I think those are things as we continue to advance, and we're starting to see that across the United States. More and more aggressive systems are doing that exact thing of, you don't need an ambulance, here's your option, this is your option, right? We haven't got to that point within this community, and it's going to take a lot to get there. On the financial piece, I think it's also important, it's a shared expense. Mm-hmm. So, you know, we are also funding a large portion of the nurse navigation piece with just with that small percentage of the subsidy from you guys to help supplement it. So there definitely is a cost sharing related to that. So I think that's important too.
Commissioner Rippon, Commissioner Mays, other questions or thoughts?
When we first implemented this, were we usually We're using ARPA funds, right? Is that?
Yes, sir.
And how are we transitioning as those funds are gone?
That was going to be what we encumber at the end of the year and continue from April to December. It'd be the same price of $5,000 a month. Probably looking at the fuel prices for both AMR and our first responders, as well as others, plus the labor prices of pulling people out. I think it's well worth our $5,000 a month that we pay to AMR to take care of this for us. That's why we wanted to encumber at the end of the year. It would be then paying for May through December of '25 out of encumbered funds that are left over at the end of the year. If we have them left over, if we don't, then we look for places to help them finance this shared, as John said.
Mr. Mays?
Well, I just, want to make it, I think it's important to note at least that the reason we did this wasn't necessarily to save money.
Yes,
It was
sir.
to free up resources, because at the time that we approved this, all the hospitals were on diversion. If you called an ambulance, it would be a while before they showed up, because they were sitting at the hospital waiting to drop off patients. And this was sort of an extra tool to free up those resources and provide better services to the community. And if we save money, that's fantastic, in the long run. But I think it is a good program, and I think it's just now like getting to where it's really working. And so I'm all for continuing it for another 2 years.
I would refer to this chart. AMR, during my tenure since 2012, AMR has only been out of compliance 4 months, and that was in 2022 when we come out of the pandemic, didn't know what to expect, and for 4 months over the summer and fall, they just got hammered. I mean, literally, there were those times. The only other time they've been out of compliance that I've been able to find in the archives in the 40-year history was in 2000, when a computer program ate all their statistics and they voluntarily took a hit for a quarter of uncompliance. According to this chart, they would have been out of compliance, 1, 2, 3, 4, probably about six or 7 months. That's where the nurse nav has come in and pulled those out. The other thing, and it's in the report, but it was not on my presentation, is I look at calls to make sure that they're not trying to game the system. There's always going to be that opportunity that people believe that there's a way to game the system, and there is, but with the documentation that I am provided by AMR and the raw data that I look at, I have not found that to be the case ever in this program yet. If it was unintentional. There are still growing pains, Commissioner. I think we are finally, and don't quote me on this, I think we are finally to a point where we are hopefully going to see a lot of these calls level out. This will be our 3rd winter out of COVID that we see. How do those runs go? So, and the hospitals, they are going to probably continue to be on diversion. Their waiting rooms stay full probably 20 hours a day of people wanting to get in there. And some of the folks that John mentioned, yes, if you came in on an ambulance 20 years ago, you pretty much got a room. They've got beds or something to put you in, but you're not going back to the ER. Even if you have mobility issues, they are really strict about who gets triaged as what, and they also keep track of who's in their ED. So the chance if somebody gets worse, they know that and they can get them immediate help.
Okay. Questions? No? All right.
Thank you both.
Thank you, Nelson.
Thank you.
Thank you, Mr. Antrim. That brings us to our next item, which is public comment. Is there any member of the public that wishes to comment this morning? Seeing none, That brings us to administrative communications. Is there any department head or mission employee that wishes to speak? Okay. Commissioner Ripplin, anything?
Nothing to report.
Commissioner Mays?
Nope.
All right,
For me.
then we'll see you on Thursday. We're adjourned.